Good evening. Welcome to our webinar today. Today's webinar will be on infertility management. Our topic will be on the intrauterine insemination in Hong Kong, option of public and private collaborations. So today is our honor to have Dr. Grace Wong, who is working in Family Planning Association, to share with us for her working experience and also the service there. So let's start the first part of our seminar, which is on the intrauterine insemination. I'm Dr. Kathy Chung. I'm working in Prince of Wales Hospital. So under the umbrella of assisted reproductive technology, ART treatment, actually it consists of two treatment modalities. The first one is the intrauterine insemination with or without ovulation induction. The second modality is the most famous one, which is the IVF treatment. So basically, these two methods is being considered as ART treatment. So the main issue regarding the use of IUI is we perform the intrauterine insemination around the time of the lady's having her ovulation. For example, if the lady have a normal ovulation, we will try to time her date of ovulation and perform the IUI procedure. In our center, we usually will making use of the hormonal monitoring. We will arrange the lady to come back on her first day of period, call us on her first day of period, and then we will see her on her second or third day of cycle. During that time, we'll perform a baseline ultrasound scan to look for any abnormality over her ovary or the uterine cavity, like any polyps. And then we will also measure her blood level to see her baseline FSH, LH, and E2, is it within the lowest level. And then we will monitor this lady for her hormonal level throughout the middle part of her menstrual cycle. For example, if the lady have a 28-day cycle, we'll try to arrange the hormonal blood test starting from her day 10 of cycle. During that time, we'll monitor her LH level and also the estradiol level. Because you can appreciate here, there is the rising of the estradiol together with the increasing in size of the follicle before the ovulation. Well, before the LH surge, there is a surge of estradiol first, and then it will going down the level. And so that we can here find there is a cross of the changes in these two hormones. After there is a surging of the LH, we will arrange the lady to come back for the IUI treatment around 30 to 36 hours later. And I understand that in some center, because the close blood monitoring may not be feasible, sometimes they will ask the ladies to do the urine test for the LH kit. And the same rationale behind is try to detect the LH surge, when will be the LH surge, and then they will call the center up and the center will arrange the IUI for her 1 day afterwards. Apart from the hormonal monitoring, if some lady doesn't want to have frequent blood testing, we'll also make use of the ultrasound monitoring about the follicular growth. Similarly, we will do the baseline scan on the second or third day of her cycle. And then we will invite her to come back 2 to 3 days before her expected days of ovulation. We'll measure this follicle and according to the size to determine whether it's mature enough to do the ovulation trigger. And for the follicular size, we'll take the average of the two perpendicular measurement for convenience. Obviously, by taking the average of 3 dimensions of measurement of the follicle will be much more accurate, but it may not be feasible in normal daily BC clinic. So once the follicle reaching the size of 16 to 18 millimeter, then sometimes we will also help to time the date of the IUI by giving this lady the ovulation trigger in terms of HCG injection. So, but usually IUI will be done together with the ovulation induction, especially for the lady that also have an ovulation problem, like those with polycystic ovarian syndrome. So the procedure schedule is like here. We also we will arrange the lady to come back on the second or third day of her cycle, and then we will do the baseline monitoring, and then we will teach the ladies to do the gonadotropin injection, which is the ovulation induction. So this injection will be given in the form of subcutaneous injection, so that once the lady acquires the technique of injection, she can do the injection comfortably at home every day. Because usually this injection needs to be done for at least 8 to 10 days, depend on their response. Sometimes for the lady that with polycystic ovarian syndrome, or even for those with hypogonadotropin hypogonadism, they even need to have a very prolonged period of gonadotropin injection, say maybe up to 3 or 4 weeks. So during this hormonal injection, we will arrange the lady to come back every few days, because we need to do an ultrasound on them to have a close monitor about the follicular size. And once there is at least one mature follicle, then we can time the date of giving them the HCG injection in order to schedule our IUI treatment. So, but in our IUI treatment, we are aiming for monofollicular response. If there is more than 3 mature follicles near the date of HCG trigger, it's not safe to proceed, because it may end up with high chance of having multiple pregnancy. And so if more than 3 mature follicles resulting from this treatment, we need to cancel the treatment anyway. And also need to advise the lady not to have even the sexual intercourse by themselves. So during the IUI procedure, it's just like a general gynae examination. It's an outpatient procedure. It takes for around 5 minutes. So we will insert the speculum into the vagina, and then we will make use of this thin catheter and connect it to the syringe. And within the syringe, we will our embryologists will draw those washed semen sample into it. And then through this tubing, we will inject the washed sperm into the uterine cavity, and the procedure is complete. And after this procedure, if the patient have the ovulation induction using the gonadotropin, we will supplement them with the progesterone. And we will schedule this lady to come back to do the pregnancy test around 2 weeks later, because by that time, we will know about this treatment cycle is successful or not. Before we can arrange the couple to undergo IUI treatment, obviously we need to, the prerequisites for IUI treatment is normal and patent tubes. So for the first line of the triple investigation will be so-called the HSG, hysterosalpingogram. Usually in Hong Kong, it will be done by radiologists, and sometimes maybe seldomly will being done by gynecologists if he or she is experienced in doing that. And then here is the picture showing a normal HSG image. This is the contrast outlining the fallopian tube. And if it's patent, then this contrast is being released to the pelvic cavity and have a fill spillage outside, and also similar for this side. If the tubes is blocked, the contrast cannot be passed through. And so here you can appreciate there is the blockage of the left tube over the corneal region. But sometimes this HSG have this limitation is that it may not be resulting from the true blockage, but sometimes it's just due to the tubal spasm, due to the pressure inside, and causing the contrast cannot be passed through and resulting in a false positive blockage image here. Here is the image showing the lady that have the blocked tube and also with a hydrosalpinx. In our center, we will try to classify the patient that with low risk group that will have go through the HSG as a triple test. But for some lady that's considered to be a high risk group, which is she has the history of pelvic inflammatory disease before, or sexually transmitted disease before, or history of pelvic surgery, then we will arrange them to undergo this gold standard of triple assessment, which is called the laparoscopic chromotubation. And however, this procedure needs to be done under general anesthesia. And we need to do the laparoscopic surgery for this lady and putting in the telescope and also the instrument. And at the same time, we need to put in a catheter into the uterine cavity to inject the dye. In our center, we will use this uterine manipulator and just like a Foley catheter, but with a rigid handle here so that it can help us to mobilize the uterus during the surgery. And by putting in this manipulator, we'll inject the dye through this end and force the dye all the way into the womb, the uterine cavity. If the tube is patent, then our colleagues in the laparoscopic side can see there is the spillage of fluid dye from the fimbrial end. And the beauty of this method by checking the tube patency is that apart from the as a diagnostic purpose, it can also achieve a therapeutic purpose. Because during the surgery, if we found that there is some pelvic endometriosis over the pelvic cavity, or there is some flimsy adhesion around the tubal end, and all this cannot be diagnosed by using HSG only. So during the surgery, we can do the ablation of the pelvic endometriosis or do the adhesiolysis to try to free all those flimsy adhesion, so that finally the lady can still be benefited by proceeding for the IUI treatment to optimize their chance of success. So apart from the patent tubes, normal or borderline normal semen and semen parameter is also required before we can design this couple for IUI treatment. The latest WHO laboratory manual for examination and process of human semen was released last year. Actually, this laboratory manual has been using for over 40 years, and there were total 6 editions being released. The first edition is being back to 1980, which was more than 40 years ago. For the last version that we have been using for more than 10 years, which was the 5th edition, released in 2010. And the latest one, just I mentioned, is being released 1 year ago. Regarding the 5th edition, that means the last edition that we have been using, is this manual facilitate the standardization of the semen analysis procedure through a detailed step-by-step approach to various basic and optional semen tests. And it also added much to the female infertility practice, both from the clinical and research perspectives. The reference range being used in the 5th edition actually were derived from around 2,000 fertile men over 8 countries whose partner was able to get pregnant within 1 year. How about the latest 6th edition that released last year? It's aimed to address the drawback of the 5th edition related to the demographic underrepresentation of some geographic region. And the data within this 6th edition combine the data of the previous 5th edition with the additional new data of fertile men being collected over the past 10 years. So at the end, this 6th edition WHO manual contained the result of semen sample being collected from over 3,500 fertile men. It consists of 1,800 subjects from the 5th edition with another 1,800 new objects. Apart from increasing the number of the sample size, They also added the data from 2 countries from Southern Europe, which were being underrepresented in the previous edition, along with 2 additional countries from Asia and 1 country from Africa that lacked representation in the previous release. However, some geographic areas, such as the South Africa and America, still remain underrepresented. So here is the summary and the comparison between the last 5th edition and the latest 6th edition. You can appreciate that they are actually more or less the same, with just the semen volume being 1.4 mil in the latest edition as compared to 1.5 mil for the last edition. And the total sperm number per ejaculate is the same, 39 million. And the total motility is being a little bit increased to 42%. And for the normal form, the morphology is also taken as 4% as the lower 5th percentile. And this is being published in, also being evaluated in the journal that published last year. So what are the common indications for the couple that are being considered to be suitable or maybe benefit from the IUI treatment? The first group of couple is being suffer from those coital problems. That means they cannot achieve a normal sexual intercourse by themselves, maybe due to vaginismus or due to the ejaculation problem. But for this group of couples, our mainstay of treatment is still to refer them to see by our specialists work in the psychosexual clinic, because some of the or most of the couple may finally benefit from having those psychosexual therapy, so that at the end they can achieve the normal sexual life and achieve the pregnancy by themselves without the need of IUI. Second group of the couple that may benefit from IUI is those with the borderline or mild abnormal semen parameters. And after the semen washing, the concentration and those most motile sperm can be picked up and then to be injected into the uterine cavity. The third group is those that suffer from unexplained infertility of young female age. That means after the investigation of ovulation, semen analysis, and also the triple test, all of them are normal. And so in our center, we will still offer the IUI treatment to see whether these are helpful for this couple. For the success rate of the IUI per cycle is around 10 to 15%. But maybe for the couple that with coital problem, the success rate is a bit higher than this value. So after talking about all this information and which group of couple may be benefit from IUI treatment. However, back to reality, in our public hospital, there's still a long waiting time for this couple to see us in our infertility clinic. For example, in our clinic, this couple need to wait for 1 year, saying counting from the dates that they submit their referral letter up to the date that they see us in the first clinic visit. For those couple that with special problem, say after some of them may already have a detailed investigation in other private center, already found that they have the severe abnormal semen analysis, or some of the lady may confirm to have blocked tubes, or even with history of ectopic pregnancy with the salpingectomy being done, they will be channeled to another designated clinic, which the waiting time will be much shorter. After this couple being seen in our infertility clinic and after being worked up, the waiting time from that time up till the date of receiving the proper IUI actually is not too long. It's just need to wait for around 1 to 3 months time. And also the IUI service is being widely available in 9 HA hospitals, including Cornwall Hospital, Prince of Margaret's Hospital, our hospital, PYH, QE, Queen Mary, UCH, TKO, and also Treatment Hospital. And I think the waiting time is more or less the same. And according to the current policy, this couple is eligible to receive up to 3 cycles of public funded IUI. That means it costs very little. They just need to pay maybe a few hundred for the whole treatment cycle. Maybe just pay for the outpatient clinic visit only. Provided that this woman is still younger than 40 years of age by the time of treatment they receive. And also this couple did not have any living child resulting from current relationship. Other prerequisites for this couple that eligible to receive this public funded IUI is they should be medically and also mentally fit for parenthood before we can offer this treatment for them. So in some special situation is for the couple that with coital problem, they may probably be benefit from further IUI trial after receiving this free public funded cycle before moving to IVF treatment. So, and also some of the couple may find IVF treatment not acceptable to them. They want to have further IUI because during the IVF treatment, although it usually generally will have a higher successful rate, however, this lady need to receive a high dose of hormonal injection because in contrast to IUI treatment, which only require maybe monofollicular response is good enough for the treatment to proceed. For IVF treatment, we intentionally want to achieve a multifollicular response because we understand that not all the follicle we are able to get the eggs out after the oocyte retrieval procedure. And also not all the eggs will be fertilized by means of conventional IVF or even use the special technique called the intracytoplasmic sperm injection. Also, not all the embryo will be of good quality enough to be considered to be suitable for transfer back to the women's uterus. So we need to achieve a high dose hormonal injection in order to create a multifollicular response. And some of the ladies may find this extra high dose injection to make them feel very discomfort, like with extreme breast tenderness or abdominal distension, which to them found to be unacceptable. Also, during the IVF treatment, the clinic visit or attendance will be more frequent than IUI because we need to keep a close eye on them by doing the serial ultrasound scan and also hormonal blood test to ensure they have a optimal ovarian response to our medication, and also they are being well controlled and the premature ovulation being suppressed by means of the hormonal monitoring. And also during the IVF treatment, the oocyte retrieval procedure carry the highest risk during this treatment modality, because for the oocyte retrieval, we need to do it usually by means of vaginal route. Apart from the transvaginal probe insertion, we also need to puncture a long thin needle through the vaginal wall into the lady's abdominal region to aspirate the follicular out from the follicles. During this procedure, there may be the risk of having the internal organ injury by this needle, such as damage to the surrounding bowel, bladder, or the vessels around. So, and also some of the during the general gynae consultation for the menstrual problem or dysmenorrhea, or while the lady attending the annual gynae checkup, some of our colleagues, the general gynecologists, may encounter some couple may suffer some form of coital problem. So apart from referring them to the HA hospital, which may need to wait for a longer time. Seeking another option that with shorter waiting time is a good option for them. So any option other than public IUI service available in Hong Kong. So according to the website published by the Council on Human Reproductive Technology, there is a list of licensed centers in Hong Kong. So there were more than 20 private clinics that already with this IUI treatment license. And the average cost for this IUI treatment, because usually will be accompanied together with the ovulation induction, it costs around 14,000 to 18,000. It depends on the type and also the dosage of drug being used. And sometimes, of course, if the IUI treatment is being done using just the natural cycle, that means without any use of the gonadotropin, just by means of serial ultrasound or blood test monitoring, the cost will be cheaper. So apart from this private ART center, and how about the service being available in Family Planning Association? So today it's our pleasure to have Dr. Grace Wong to be here to share with us about her experience and also the related service being available in Family Planning Association. Because by knowing more available service option in our locality, as a gynecologist, we can provide more information to our couple to make their own choice. So, Dr. Wong, please.
Thank you, Kathy, for giving me a chance to introduce to the audience the Artificial Insemination by Husband Semen Service, in short, AIH, in the Family Planning Association of Hong Kong. So let me brief audience about our subfertility service in the Family Planning Association of Hong Kong first. Actually, it has a long history dated back to December 1956 when this service was first commenced. I think this date is well before the birth of majority of the audience. It is a self-referral services, meaning that there's no need of any doctor's referral for the couple to attend our fertility service, because at that time we are basically only offering some primary fertility care, including some health education to optimize the chance of the couple being able to get pregnant, like giving advice on smoking cessation, giving advice on coital frequency, and optimizing the body weight of the female partner, especially for those obese polycystic ovarian syndrome patients, through referral to our dietetic service. We also do some basic workups, like we check whether they have any ovulatory problems. We will also look into whether they have any tuboperitoneal factors for fertility. We'll also do semen analysis to check for male factor. So for those with ovulatory dysfunction, initially we are offering them Promeds to optimize their ovulation. And subsequently, we also introduce letrozole for those women with polycystic ovarian syndrome. And we also have counseling service if the couple express that they have tremendous stress from all these fertility problem as well as the investigation. However, if we didn't manage to help those couple to try to get pregnant through this primary care, then our next step would be referral to secondary and tertiary center. However, as Kathy has pointed out, for the secondary and tertiary care, especially under the publicly funded service, there's usually a long waiting queue. So that's why we are faced with a group of distressing patients asking us, what should they do during this waiting period. So that's why it leads us to think about whether we can offer more. So this lead to the development of the artificial insemination by husband semen service in the Wan Chai Sexual and Reproductive Healthcare Center of the Family Planning Association of Hong Kong. We start operating since March 2013, and basically we are providing ovulation induction using oral ovulating agents together with intrauterine inseminations for our existing subfertility clients. That means it is an internal referral system. The main indications for such AIH treatment would include some mild male factors or some women with minimal or mild endometriosis. Sometimes both the male and the female partners could have problems, but they are just mild problems. As Kathy has pointed out, for some couple with unexplained subfertility, but they are not keen for having IVF because they think the treatment will be too traumatic to them, and as well as providing treatment for couples with coital problem. But we have the advantage in the sense that we have sex therapy in the Family Planning Association offering treatment for couple with non-consummation. So the waiting time for our own patients, it's in general around 2 to 6 weeks time before they can have the treatment with us. And fortunately, from January 2016 onward, we are able to provide an in-house sperm wash in our own andrology laboratory, collaborating with Hong Kong U. So what are the criteria for the internal referral of the subfertility clients to our AIH service? So first of all, we must act according to the law. So according to the Human Reproductive Technology Ordinance, the reproductive treatment procedure should be offered to parties of marriage, meaning that it should be legally married couple. And as Kathy had pointed out, the women should not have any uncontrolled physical or psychological conditions which may cause adverse effect to the pregnancy or may have a possibility of affecting the welfare of the offspring. We would like the female partners to have bilateral, patent, and normal tubes as proved by a hysterosalpingo foam sonography or HIFOC or foam test, which was just recently introduced in the family planning, or confirmed by hysterosalpingogram as pointed out by Kathy previously, either the conventional fluoroscopic hysterosalpingogram, meaning under X-ray, or CT hysterosalpingogram, or couples have previous laparoscopy demonstrating tubal patency. We also required the male partners to have the total motile sperm of more than 10 millions. And the female partner should not have any history of allergy or severe adverse effect towards the chromate used. And they need to accept a pregnancy rate of only around 8 to 11%, with a multiple pregnancy risk of about 10% after chromate. And they should not have previous IVF treatment. So what is the workflow of our service? So we will after the checking the eligibility criteria in our fertility clinic, there will be a referral to us for counseling. So during the counseling, we will explain to the couple the procedure of the artificial insemination by husband semen. We will explain to them the possible risks involved in the treatment, like the risk of multiple pregnancy and the possibility of fetal reduction, small chance of having pelvic infection during the intrauterine inseminations. We will also tell them about the cost of the treatment. The median cost for one cycle of treatment would be around 7,000 to 8,000 Hong Kong dollars. And we also need to explain the limitations of our service. basically we won't be offering any services during weekends or public holidays. Then we will ask the couple to sign a consent form. We'll be offering them Chromid for ovulation inductions. And for women with polycystic ovarian syndrome, we'll offer them letrozole for ovulation induction because it has been demonstrated to have a better effect on ovulation induction versus Chromid. And then we'll do monitoring as what Kathy have tell us before. We'll do the follicular tracking using a transvaginal ultrasound. And occasionally, we may need to use hormone to complement our monitoring of the follicles. We'll ask the women to do, we were actually doing the urine LH test for the women when they come for monitoring to check for whether there is any surge in the urine LH level, suggesting that they are going to ovulate soon. So if the leading follicle is more than 80 millimeters, and if the urine LH is still negative, we can give an HCG triggers at what Kathy has suggested and offered the insemination around 36 hours later. Or if the women have a positive urine LH test, then we will be arranging insemination on the next day. So occasionally, we may need to use some luteal phase support in terms of vaginal progestogen for those women with thin endometrium. Because we understand that Chromid, one of the drawbacks is it may cause thinning of the endometrium, which may potentially affect the chance of having successful implantations. And then we will be following up the women 2 to 3 weeks later after the insemination to see whether they're pregnant or not. So maximally, we'll be offering 4 cycles of such treatments to each couple under the age of 40. And we'll be only offering 2 cycles for women over the age of 40 because we understand that time is precious for those women over the age of 40 in terms of fertility treatment. So we understand that such IUI treatments, the success rate is not as good as IVF. So if they have already a goal for the IUI, but yet it's not successful, we'll urge them to consider a more rewarding form of treatment. So let me share with the audience about our statistics. So up to the end of last year, we have been counseled about, have counseled 459 couples and do 880 inseminations. So this graph actually shows the age distributions of our female partners. Majority of them would be in the early 30s, but still there is about a quarter of them belongs to the advanced maternal age group. And maybe because our fertility clinic is a self-referral clinic, couples don't need to wait too long to be seen. So you will also appreciate that for the duration of fertility of our treated couples, majority of them have a duration of fertility of less than 2 years. But you can still also appreciate slightly less than half of all our treated patients, they could have fertility problems for more than 2 years. And 3/4 of them suffered from primary fertility, and about a quarter of them suffered from secondary fertility. So according to the causes of their problem, majority of them are actually having both male and female factors of fertility, followed by those having male factor alone, and then followed by the unexplained fertility, and finally those with ovulatory factors fertility. And this is the outcome of our service. We managed to have 100 pregnancies by the end of last year, and there is 78 live births. I said +6 because there's some multiple pregnancies. So in total, there will be 84 babies. But unfortunately, there will be 9 miscarriages and 13 biochemical pregnancies. Out of these 100 pregnancies, 8 were multiple pregnancies. We have 7 pairs of twins and 1 triplet pregnancy. And overall, around 31% of all of our counseled couple ultimately managed to get pregnant either spontaneously after counseling or after ovulation induction with or without inseminations. However, we still have a cycle cancellation rate of around 9.3%. There is various causes for cycle cancellation, including some personal or social factors, such as the women didn't have the time to come back for the insemination procedure, or husbands didn't have time to submit semen during the sperm wash time, or they have difficulty in submitting the semen sample. And we did have some cases of premature egg exsurge, so leading to cycle cancellation. And there's also some cases in which there's multiple follicular developments. And as what Kathy have said, okay, in order to minimize the higher order multiple pregnancy, we need to cancel the cycle. So as the theme of the talk today is talking about possible collaborations between public and private sectors. So what I can perceive is if collaborations can be offered, then it can smoothen the flow of patients between different level of cares. So rather than patients being felt being like a ball kicking around different surfaces, we will be able to shorten the waiting time for patients and then hasten the targeted treatment for appropriate patients. So what the Family Planning Association can contribute is we can, if there's a long waiting time in the publicly funded service to see their fertility service, then we are, if the couple is affordable, then they can do some basic workup in our clinic. And as Kathy had pointed out, some couple with coital problem, then they can also receive some sex therapy for their coital problem. And another thing we can think about is actually whether there is any share care possible for ovulation inductions, especially for those women with polycystic ovarian syndrome. So previously, we used to have a share care program with Prince of Wales Hospital, but subsequently, this share care is no longer functioning, but this is one of the directions we can think about. And if the couple would like and affordable, they can consider receiving the ovulation induction and intrauterine insemination in our service while awaiting for the IVF treatment in the tertiary centers. And then, on the other hand, we hope that the secondary and tertiary center can also contribute to the collaborations by fast-tracking patients who have already been properly worked up on their fertility problem for subsequent management. But I'm happy to hear from Kathy that this has already been the case, because there's different queues for different treatments. Some queues for the IUI treatment, but there is some with, for example, bilateral block tubes, then probably they will be scheduled for an IVF treatment. And we also hope that whether there could be some streamlines for referral for some surgical fertility treatment, such as hysteroscopic polypectomy prior to IUI, which can hopefully improve the success rate, or some metroplasty for women with uterine abnormality, etc. So I would like to end my sharing here, and I would like to invite the audience to have some brainstorms on how we can have better collaborations in the public and private sectors, and hopefully can benefit or improve the fertility service provided to Hong Kong populations. Thank you.
Thank you, Dr. Wong, for your excellent talk. And so, regarding the streamlined referral, I think it's very important that there are other options that, apart from the HA service, that the patient can seek the help from either private or FPA, so that they can have early investigation and also, or even the early IUI treatment. Because, for example, if some of the couples that have maybe borderline male factor, if they already receive the investigation and also IUI service, say in FPA's in FPA, but unfortunately still cannot achieve pregnancy yet, then after they are being referred to our clinic, we can already help them to queue up for the public IVF service. Because if for the couple that without doing any IUI before, if their case is not justified for direct IVF, then it sometimes we think that they still benefit from IUI, but their waiting time for IUI, and then it failed for 3 cycles, and then waiting another maybe 9 months to 1 year for the public IVF service, I think is too time consuming for them. So I think also for the FPA service, in terms of waiting time and also the cost issue, I think it really provide a good option for our patient, somewhere in between the HA service and also the private service. So hopefully, another aim of this today's webinar is try to maybe increase the awareness among ourselves, whether there is any other option of infertility service available in our locality, so that we can provide sufficient and also accurate information for our patient to guide them through their journey to the pregnancy.
I totally agreed with what Kathy has suggested. Okay, because we understand that there's resources limitation in the publicly funded service, together with a manpower shortage. So we understand sometimes for the initial waiting time to be seen at a fertility clinic is pretty long before they can be channeled to subsequent investigation or channeled to other treatments. So that's why what Kathy suggests is correct. If we can streamline some of the investigations or some of the referrals, so that those who have already been properly worked up or have already tried IUI but still failed, then they can be fast-tracked to the IVF queue. Then it will sound more reasonable or logical to patients to understand how they should be facing their conditions.
So any questions from the floor? So let me check. There is a question from Dr. Kwa. Are there any standard protocol on OI drugs used for public and private prior to IUI, such as the type of ovulation induction drug and dosage? So standard protocol on OI drugs. In our public and also because our COHK also have the private center, the standard protocol in our center, usually we will use of the gonadotropin, either of HMG or the FSH. Unless the patient suffer from a hypogonadotrophic hypogonadism, we must use the combination of LH and also FSH. And for the dosage, we usually, maybe if the lady need to have a daily injection, we usually put her on maybe 75 units per day. And then we will usually they will need to have the injection for 8 to 10 days, depend on their response. So also a question from Dr. Hua. How frequent is the follow-up for the ovulation tracking in FPA for an IUI cycle? Is there any one center that is in Wan Chai that offer IUI? Is there only one center being offer IUI, which is in Wan Chai?
Yes, only the Wan Chai Sexual and Reproductive Health Center is licensed for the IUI treatments, because we need to apply a license before we can perform such treatments for our patients. So, and then usually we will be offering them oral ovulation induction agent. Usual patients, we will start with Promid. We start with 50 microgram. 50 milligram Promid first for 5 days. And then if we see that the response is not satisfactory, then we will step it up to 100 milligram the next cycle, or 150 milligram the next cycle, depending on the conditions. But as I said, we also introduced letrozole as an oral ovulating induction agent for those women with polycystic ovarian syndrome, because studies have demonstrated that using letrozole can achieve a better ovulation rates as compared with Chromid. And then also it have less adverse effect on the endometrium, and also has less adverse effects on the cervical mucus. So that's why it is one of the options for oral ovulation induction in the family planning. Usually we will start the ovarian tracking on the day 10 of the woman's menstrual cycle, but it also depends on how is her cycle length. So that's why in the family planning, we will usually ask women to keep a temperature chart. Okay, although we understand the temperature chart is no good in terms of helping couple trying to conceive, but we find that the temperature charts occasionally can help us, or help the woman to understand how their cycle is, and then can occasionally tell us when is the likelihood of the woman having her ovulation time. So in such a way, then we find it will be less demanding for women to come very regularly for the ovarian tracking, if we can have some more information about their usual ovulation pattern.
Another question for Dr. Wong. What is the estimated waiting time for sex therapy in FPA for couple that with coital problem?
Because for the sex therapy, we would like it, because the sex therapy in the FPA was initially planned for those couple with non-consummation. So usually we will recommend those couples to participate in some sex education talk first, to know the basics about the anatomy of the reproductive organs. Okay, what would be their feelings, okay, when they have sex. Okay, and then after some basic talks, then we will arrange them to see the sex therapy. And then even for sex therapy, there's two streams. One is seeing a clinical doctor to assess whether there could be some organic pathology for the coital problem. And then there's another part, which is seeing our counselor for some psychological support on their anxiety for having sex. So the waiting times actually fluctuates depending on the caseload, and usually it may take a few months, okay, before they will be able to be seen by the sex therapy. But as I said, before they were being seen, they have already been channeled to have some basic educations about sex, and also of their response, organic response to sex. So actually they are continuing until they're finally being assessed by the sex therapy.
So may I ask, what is the estimated cost for each sexual therapist clinic attendance?
So I'm sorry, I didn't have the actual price list at hand. So but usually it would be I would say the consultation would be less than $1,000 per visit. But it depends on how the couple is responding, whether it's responding to the sex educator teaching on how to do the exercise. So then it depends on how fast they will be successful in having their own coitus. Then the total cost will be determined by how well they're responding.
I see. So because we PWH also have the sexual clinic available here, but we still have a waiting time, and also we can only offer the treatment for those couples being referred to our infertility clinic. Yeah, so I think the sexual clinic in FPA is also another option for those couples. Okay.
I hope we can provide some service to other other referrals as well.
Definitely. So I think maybe the previous problem may be lack of awareness among us. So we don't know there is any extra service being available in other place or organization. So after today, maybe we can, or you may receive many referrals. Thank you, Dr. Wong. Thank you, Dr. Wong.
Maybe we can further discuss later on how can we smoothen out those referral system to, as I said, hopefully reduce the feelings that sometimes patients tell us they are just like being kicked around different services.
Yeah. Thank you, Dr. Wong. So if no further question, we are going to end our webinar today. And thank you all for your attendance today. And so for those local ONG specialists, please stay behind, because we are going to post the QR code for the CME point registration. Thank you. Thank you, Dr. Wong.
Thank you.